Hello, ladies and gentlemen, boys and girls, cats and dogs. I'm Dr. Ken Berry, a family physician, and it's my privilege and honor to bring you a special guest this hour for this edition of Monday Live at 5, Dr. Bret Scher, who's a cardiologist and a lipidologist. He's been practicing I think, since 2005. I'll get the details when I bring him on. But we're going to be talking about all things heart health, cardiology, and keto. And so if you have a friend or a loved one who's thought about keto and they're like, I don't know, my doctor said that it would make me have a heart attack, this is the conversation you want to listen to. So text them, call them, go get them by the hair of the head and sit them down in front of this. You can watch it live and ask your questions. And if we get to the question, we can definitely answer it right now, but this will be available to watch on the replay on both YouTube and Facebook forever. And so if you can't get a handful of their hair right now, you can just have them sit down tomorrow or the next day and watch this on either Facebook or YouTube. Now let's get Dr. Scher in here because I'm sure you're tired of hearing me talk already. Hey guys, jump on, tell me where you're watching from. And if you have a question for either me or Dr. Scher, a cardiologist, a heart doctor, a heart specialist, a lipidologist, that means he knows about cholesterol, then put your question in the comments, and we'll try to answer as many as we possibly can. All right, let's see if I can grab Dr. Scher. There he is. Hey, doctor, welcome.
Hi, Ken. Thanks for having me on.
Man, it's such you and I, every time we chat, it's always the best chat. So I'm excited to hang out with you here for an hour. So you've been doing well during this time of crisis. It looks like you're doing well. You've been coping okay?
Yeah, all things considered, there's the professional life, there's the personal life. And fortunately, from a professional standpoint, I transitioned to a telemedicine practice about a year ago and became the medical director of dietdoctor.com. So that's a remote job too. So I was sort of preparing for this for a year, I guess you could say, unfortunately.
Yeah. You're practicing already, so that's good. Yeah.
Yeah. I already had a telemedicine practice. And then, the hard part is just having the kids at home, trying to do their schooling and keeping them engaged and, and all the social things everybody's going through. But all things considered, I got to say we're hanging in there pretty well. Just looking forward to hopefully everybody getting back to a normal life and, as soon as possible.
Absolutely. I totally agree. So for those people, for the three people out there who don't know who you are and what you do, tell us who you are and what you do, your credentials, and why we should care about what you have to say.
Yeah, well, I'm a traditionally trained cardiologist. I did my actually preventive cardiology fellowship and general cardiology fellowship, and went out into the world as a general cardiologist trying to stamp out heart disease, and thought I was going to run out there and save everybody I saw. And through the course of reality setting in, realized I wasn't having the impact that I really wanted to have on people. And that led me down this course of starting Boundless Health, which was sort of a boutique wellness center. And I was fortunate enough to work with a health coach who knew a lot about ketosis. And he convinced me to try ketosis and a ketogenic diet and a couple of our clients. First, I thought he was crazy. Thought he was an alien with three heads trying to tell cardiologists to tell people to eat fat. What are you, crazy? How can you do that? But that led me down this path to actually look at the research, actually read the books, actually read the papers, and actually try it on myself and my clients and change the way that I practice and live forever. And through that course, became the medical director at dietdoctor.com, became a certified lipidologist, and now have a telemedicine practice focusing mostly on keto, low carb, and lipid issues, but really anything in general in terms of cardiovascular health, cardiac prevention, either in low carb or out low carb. So that's what sort of led me on this journey. And through the process, though, I also realized to really impact people, you need more than just knowing medicine. So I got trained in personal training and behavior modification and nutrition, and got some extra certifications to help me along the way, which hopefully helped me see things from a broader perspective.
Yeah, and I think that's super important. Regardless of what kind of physician or doctor you are, I think you need to understand human nutrition. I think you said that perfectly. And so many doctors, and you can think about the orthopedic surgeon who's like, well, why should I know about nutrition? I'm a carpenter. Well, the healing of bones and the healing of tendons and ligaments that has to do with your diet. And so I don't think there's a medical specialty out there, except maybe pathology, where, human nutrition, that is the foundation of your medical training. And most medical schools don't see it that way. And many doctors don't see it that way. But I think in large part because of the work you're doing, I think many heart doctors are like, oh, nutrition. No, I guess that could be important. Maybe I should look into that. So I totally applaud you for that. And did I read correctly? You used to be a triathlete. Is this correct?
Yeah, that's correct. I grew up in San Diego, the triathlon mecca, where you can be outside training 360, probably 3 days a year. And so I was just lucky and stumbled into it as a little 14-year-old. A couple semi-pro triathletes here in town took me under their wing and kind of tutored me, and I became a triathlete and competed all through high school and college, and even a little bit in medical school. I did an Ironman my second year of medical school. Then life sort of caught up, and triathlons have been something of the past, but it'll always be a part of me, and I'll always be a cyclist and a runner and a swimmer until the day I die, I hope.
That's pretty impressive. That's sexy, Brett. I love that. So I think what most people want to hear about, because they've heard my crazy redneck family physician perspective on this, but they need to hear it from a cardiologist and a lipidologist, board certified in both. So is keto going to make me have a heart attack? Is keto going to block my arteries? Is eating cholesterol going to clog my arteries? Is eating keto going to give me A-Fib or a flutter? So however you want to begin to unpack that, I want you to take the floor and unpack that and help us understand from a cardiological specialist what you think about that.
Yeah, well, I think the place to start actually is if you would have asked me this question in 2005 when I finished my cardiology training, I would have said, yes, you are absolutely right. Eating keto is going to give you a heart attack. It's going to clog your arteries, all that fat and the cholesterol. That's what it does. We know that. That's what I was taught.
We know
that, right?
Yeah.
That's what I was taught. But then when you go back and you look at it and you see the emperor has no clothes, or it's built on a house of cards, you can think of your favorite analogy. Because it turns out all of that is based on very poor quality nutritional epidemiologic studies. That's all it's based on. And some people will say there are some mechanistic studies as well, but everything that looks at it is a high carb, high fat diet. And there are confounding variables and healthy user bias, which means those who weren't eating fat during those times of the studies were also doing other healthier activities. They were paying more attention to their health. The people who were eating more fat when all the world is telling you to go low fat, chances are you're doing other things that aren't so good for you. So all these confounding variables in a study that doesn't control anything, doesn't tell you what to do anything, just lets you live their life, and has razor thin differences in terms of who has heart attacks and who doesn't. That's the evidence that was taken to inform all the doctors that eating fat, eating cholesterol is bad for you, and you need your healthy whole grains, you need your high carb diets. So it really it's once you step back and look at it and get rid of your blinders that unfortunately so many people in medicine have, you see that it doesn't stand up. The evidence doesn't support it. And we have randomized controlled trials. We have other observational trials that are in direct conflict to everything that I was previously taught and most doctors were previously taught. So the bottom line is, does eating fat cause heart disease? Does eating dietary cholesterol cause heart disease? There is no quality evidence to show that. So, I have treated hundreds of patients, if not more, with heart disease and without heart disease, probably thousands of patients now, with high fat diets, with good conscience, because there is no science. If there was a clear scientific evidence that it was dangerous for this person sitting in front of me, I wouldn't do it. My job, my whole calling is to help people improve their health and improve their lives. So why would I do that? But once I see that evidence isn't there, all of a sudden it changes. Now, I'm also not one to say there is one diet for everybody. Everybody needs to be on a keto diet. Everybody needs to be on a low carb, high fat diet. That's not true either, right? We got into this whole mess by saying there is one diet for everybody, that one diet being, a low fat diet, basically. We got into this mess thinking that there's one diet for everybody, and there isn't. But the fact that doctors are afraid of keto, doctors are afraid of high fat diets when there's no credible evidence to support it, that's a crime. And that's what I really think needs to change, that more doctors at least need to be aware of it and have it as a tool in their toolkit to help the right person.
Absolutely. And I know that you know this, Dr. Scher, but I'll say it for everybody else. The American Diabetes Association now has a low carb option in their diabetic protocol, but it's on page 482 in the very back of the manual. But it is actually an accepted model for a diet for a diabetic. And another thing I want to add is that a lot of people think, well, you know, the American Diabetes Association diet that they recommend and all the recipes on their website, I'm sure that stuff has been scientifically proven to be the best thing for a diabetic to eat. And Dr. Scher touched on that, but let me say, because I'm a bit blatant, I like to just say things. None of that has been scientifically shown to be not even healthy, but safe for the long-term consumption of diabetics. There are no long-term control studies showing that the ADA-approved diet is safe long-term for a diabetic to eat. And in the same vein, the DASH diet that's proclaimed by the American Heart Association, there are no long-term studies control studies showing the safety of a sodium-restricted diet in human beings. Those studies do not exist. And so if you're thinking, well, my heart doctor told me to eat the DASH diet and it's got AHA right up at the top, that's got to be safe. That's got to be proven, right? No, there is no research showing that that's not number one. It's not no research showing that it's the healthiest diet for someone with heart disease or diabetes. There's no research even showing that it's safe long term. And when I want to say that blatantly so people can go, what? Are you kidding me? And so you're telling me that this DASH diet that my cardiologist yelled at me and got emotionally upset at me because I wanted to eat keto and he wanted me to eat the DASH diet, there's just as much research supporting the keto diet as there is supporting the DASH diet, if not more. Is that correct?
Yeah, it's so interesting that people's first kind of knock on the keto diet would be, well, there's no evidence to show that it's safe or effective long term. And that assumes that there is that evidence for their diet, for the low fat diet, for the DASH diet, the low cholesterol diet. And no, that's not the case. Again, it was extrapolated data from observational studies and then sort of people's best guess and consensus opinion to recommend those diets, not because of good high quality data showing it. So yeah, I definitely would agree with that. And I think that's important for people to realize. And
I think it's so important to say it that way because people just assume. My heart doctor in that beautiful long white coat and that Cardiology 3, he said the DASH diet is the best diet. And he's not an idiot. He wouldn't say that if there were no research to back that up. But the problem is, folks, is that a lot of what doctors do is either parroting what we've memorized or repeating what we've heard from a mentor or somebody we look up to. Very, very often doctors they don't verify this stuff because doctors are busy. Dr. Scher is very busy. And so, but he did take the time to go back and actually look at the research, which I find very applaudable. Thank you, Jan Jackson, for sharing this. And that reminds me, if you guys, if your mom, your dad, your uncle, your aunt, if they need to hear this information so that you can finally convince them to go keto or carnivore or even low carb, and there's a family doctor and a cardiologist, all you got to do is click the share button and you can share this with them and then they can watch it at their leisure because, I mean, you're not going to get a much more reputable voice than Dr. Bret Scher, a cardiologist and a lipidologist. So where do we want to go from there, Doctor?
Well, I want to interject there since we're talking about sharing with physicians and helping educate physicians. That's why at Diet Doctor, we created a free CME course, continuing medical education course, where doctors can get, official certification credit, continuing education credit, official continuing education credit, which all doctors need. And it's for free. And it's to educate them about the science of using low carb. And it's all science-based, it's officially certified. And so I think every physician needs to take this. Doesn't mean every physician is going to be a complete low carb advocate, but they need to understand the science. They need to understand that what they've been taught isn't necessarily true. So please share that as well. And, you had mentioned that a lot of what the doctors do is just sort of parroting what they've been taught. And it's true. It's not like most doctors out there aren't trying to be mischievous, aren't trying to hurt you or give you bad advice. They just don't know because they haven't taken the time. Because why would you when the American Heart Association tells you that this is the right thing to do? When you see cardiologists, at conferences telling you this is the right thing to do, when you're attending physicians, when you're training, told you this was the right thing to do, it's easy just to accept that. It's much harder to question it and look into it. And that's the problem, that we really need people looking into it more because we don't realize that quality of evidence matters. You'll hear this all the time, the preponderance of evidence or the majority of the evidence. Well, if it's all poor quality evidence that you can't really make conclusions of, then I don't care what the preponderance of it says. It still doesn't matter, right? So that's part of the main problem here.
That's like saying I've got my trunk is full. I've got 100 pounds worth of counterfeit $100 bills in my trunk of my car, and it's worth so much money because it weighs 100 pounds. It's 100 pounds of $100 bills, and you're like, yeah, but they're counterfeit. That's kind of like it goes with the nutritional research. Yeah, there's lots of it, but when you start looking at the quality of it, it's there's just nothing there, and it's very sad, and it's actually a bit disconcerting to me that they even actually call it science. It really strains the definition of the word. I've got a question here, Doc. And I think this is a brilliant question, and this is the kind of paradigm I love to bring up. Somebody said, what's more dangerous, having a high total cholesterol and a high LDL, and not having diabetes, or having type 2 diabetes and a normal cholesterol and normal LDL? Which is more dangerous?
Great question. And in my whole cardiology fellowship, there was, maybe a minute spent on diabetes. We weren't taught to manage diabetes. That was the endocrinologist. That was the primary care doctor. We were cardiologists. We focused on cholesterol and arteries. But really, diabetes is likely the greatest risk factor for cardiovascular disease, greater than cholesterol. There's a lot of confounding variables there too, so hard to measure that for sure, but that's certainly my opinion. And I think there's plenty of evidence to back that up, that type 2 diabetes, high blood sugar, high insulin is a greater risk factor than isolated elevated LDL, for sure, would be my guess. And I wasn't taught that. No cardiologist is really taught that. Now, I think more cardiologists are starting to become more aware of aggressive glucose management because there's finally a drug that can manage glucose and improve cardiovascular outcomes with the SGLT2 inhibitors. But that's the problem. It takes a drug to get cardiologists or get physicians interested in this. Whereas previously, all the aggressive drug trials with diabetes showed no cardiovascular benefit when you treated them more aggressively versus less aggressively. And that's because they all raised insulin. They just masked the symptom while letting the underlying process worsen and raising insulin. Whereas low carb diets do exactly the opposite. They cut it at its core. They lower the glucose. They lower the insulin. So I can't say this is true for every patient. So I'm not going to answer the question exactly to say for everybody a higher LDL is safer or less safe. But I think type 2 diabetes is likely the largest risk factor, certainly a greater risk factor than an isolated LDL. But obviously, you got to check with your physician to see what's right for you because everybody has individual circumstances.
Exactly. And obviously, nothing that's said here today is personal medical advice for you. This is two doctors talking and trying to help educate you. And I want to talk about that just a bit more, Doc. So the big study that Dr. Scher is talking about, we thought, if we aggressively control type 2 diabetes with medication, then that should improve outcomes. And so either with insulin or insulin-raising drugs, there's a huge study, and they really jumped on aggressively type 2 diabetes and tried to keep the blood sugar normal and get the A1C as low as they could. And what they found was those people actually did worse. And Dr. Scher is exactly right. That's because they had out of control hyperinsulinemia, either from insulin injections or from the medication that raised their insulin. There's differences of opinions here, but I'm almost ready to believe that hyperinsulinemia is probably more dangerous than hyperglycemia. They might be a tie. One may be worse than the other. But here's how doctors think, and I want you guys to understand this. What the study took away from that data was that it's dangerous to control people's type 2 diabetes too tightly. And so we should stop doing that. And that's why you may have been told by your cardiologist or your endocrinologist or your family doctor or internist, hey, your A1C 7, that's fine. Don't worry about it. They're still practicing from that old study. What was that, 20 years ago? That study? Yeah, it's a long time ago.
Maybe even more.
And so that study didn't look at diet at all. And so lowering your A1C back to normal with hyperinsulinemic drugs does not help you. That is absolutely, I totally agree with that. But lowering your A1C and blood sugar back to normal with diet, with what I would consider to be the proper human diet spectrum, that's absolutely going to slash your risk. And I've actually had other doctors, Dr. Scher, say, well, why do you want to get their A1C so low? You remember the study, right? I mean, that's dangerous, right? And I'm like, dude, I'm not doing it with glyburide and Lantus. I'm doing it with their diet. I'm just fixing their diet. And these doctors, poor things, they couldn't tease that out, how that was somehow different. I'm like, that's hugely different. I'm lowering their blood sugar and lowering their insulin. You're lowering their blood sugar by raising their insulin. Do you not see the difference? And I could just see they're like, I don't know what he's talking about.
That's distressing. That's really distressing. I mean, especially when you look at the curves, like the observational trial curves of risk at various hemoglobin A1Cs, it starts to increase at 5.5. And then at 6, it starts to go up more. And at 6.5, starts to go up even more. But they say treat to 7 because it's safer. But again, drug focus versus lifestyle focus. Like,
exactly.
You don't need the drugs if you can solve the problem in the first place with the lifestyle. And that's the way physicians should be thinking. I mean, I have physicians who come and consult with me to help them develop their practice. And one of the first things I say is put your prescription pad away for an entire day and see what you do. Because when you can't write a prescription, all you can do is talk about lifestyle. And that's where they're going to start to see the benefits.
I love it. I love it. Dr. Scher, is there a heart condition in existence? And the patient comes to see you with this heart condition. Is there a heart condition where you would say, nah, you don't need to eat keto. You need to eat lots of whole grains and just eat the standard American diet or eat the ADA diet. Is there such a heart condition? And then unpack that as you see fit.
Well, so hypertriglyceridemia, isolated elevated triglycerides, is a really interesting problem, because I've found that a number of those people will respond dramatically to a low carb, high fat diet. And then there are certain variations, and I think it has to do with genetic mutations, different genetic makeups of why the triglycerides are high. And then there's certain types that really do poorly on a high fat diet and need a low fat, high carb diet to really lower those triglycerides. And I'm talking, 1,000, 2,000 for triglycerides, not the 2, 3, 400s that we talk about as high now, but the 1,000, 2,000 where you're at risk of getting pancreatitis. So it's not even so much about heart disease as it is about pancreatitis, but it's a lipid abnormality. And that's usually familial hypertriglyceridemia or lipoprotein lipase deficiency or other sort of genetic mutation. So I think that's the first one that comes to mind. And there's some people who have genetic trouble actually digesting fat, whether it's carnitine palmitoyl transferase deficiency, all these long words.
Right.
Those people won't do well on a high fat diet and need a low fat, higher carb diet. Aside from those, though, I'm pretty hard pressed to find any that would automatically do better with a low fat, higher carb diet. Yeah, because that's not to say that they can't do well on a low fat, high carb diet, right? We look at the blue zones, which is not a study, it's not science, it's just observations of people living their lives. And they live, the people in these blue zones, they live into their 90s and hundreds eating high carb diets. But they also eat 1,200 calories a day. They're outside and they're active all day long. They eat 2 meals a day. They don't snack. Everything they eat is locally prepared. They don't go to restaurants. They don't, they don't go to all you can eat buffets. The glycemic index of the food they're eating is very low. They don't have baseline insulin resistance to start with. They're not sitting behind a computer 8 or 10 hours a day, right? So we can't, extrapolate that data and say, oh, well, that fits everybody in our modern lifestyle too, that everybody should be eating that way. No, of course not. But sure, there are subsets of populations, either genetic makeups and the way their lifestyle is, that they could do just fine on a higher carb diet. So it's not that it's not that nobody can eat it, but a lot of people are sure getting big trouble with it. And it's unfortunate because our medical system sort of supports that right now.
Yeah, I totally agree. So now let's talk about cholesterol. Cholesterol has been blamed for many things. So does having high cholesterol clog heart arteries?
Having high cholesterol for people who have been studied in the observational studies has a slight association with increased risk of heart disease. Does that mean high cholesterol clogs arteries? Absolutely not. That is not one and the same. So the clogging of arteries or the developing of atherosclerotic disease is a complex, very complicated process with multiple stages that starts with vascular injury and inflammation and a healing response and cholesterol responding to that healing response and inflammatory cells and macrophages. And it relies so much on the health of your blood vessels, the type, the size, and number of your LDL and HDL, of things called your glycocalyx and your proteoglycans, which are negatively affected by high sugar and high carb diets. So it's this, let's be honest, I mean, humans like simple answers, right? We don't like complex things. And if a doctor has 5 minutes to talk to their patient, explain everything to the patient, explain how atherosclerosis happens while you're checking all their medicines and their side effects and checking all the boxes to make sure the insurance pays you, you don't have time to go into more nuance. So you want the simple answer. So the simple answer is cholesterol clogs the arteries, but no, that's not the way it works. It's far too simplistic. So that doesn't mean eating cholesterol clogs your arteries. It doesn't even mean eating saturated fat clogs your arteries. It just doesn't work that way. And in fact, I wrote an article a while ago on Diet Doctor about the American Heart Association coming out with a scientific update on dietary cholesterol. And basically in this update, they showed all the science that shows that eating dietary cholesterol is not associated with increased risk of cardiovascular disease. It's not associated. And they showed that science. But then somehow in their conclusion, they said, so we recommend eating a low-fat diet with low dietary cholesterol and low-fat yogurts and high grains. And the conclusion didn't fit all the science they just laid out. But it's pretty clear that eating high cholesterol diets does not cause cardiovascular disease.
Yeah, I love it. So a lot of people have hypertension. As you know, millions and millions of people have hypertension. So now let's talk about keto and high blood pressure. And then if you want to, we can jump into salt and high blood pressure. I love both of those topics. So will keto, if someone has hypertension, is it safe for them to eat a ketogenic diet? And then secondly, should they limit their salt and eat a low sodium diet, or should they salt to taste?
Yeah, salt. Let's take salt first. I mean, salt's another great one. Just like dietary cholesterol, that was passed down as dangerous and something everybody needs to avoid. But that's far, far from the truth. In reality, there's maybe 25% of the population that has salt-sensitive hypertension, meaning you eat more salt and it raises your blood pressure. That means 75% of the population doesn't have that association, that you could probably eat as much salt as you want. The other thing is, where's the salt coming from? Right? If the salt is coming from processed food, potato chips, everything in bags and in boxes that comes from a factory, all right, that's going to explain why you're having high blood pressure and gaining weight. If the salt comes from, your broccoli and your cauliflower cooked in butter with some, sea salts on it, or your steak that you just put some Himalayan salt on it, that's completely different. Absolutely completely different. So the idea that salt causes hypertension, again, is a falsehood. And if it's for a minority of people that it's even related. And even then you have to say, where's the salt coming from? Yeah. So the other part of your question, though, is keto safe for high blood pressure? Not only is it safe, it's recommended. I mean, the only danger is it might work so well, you're going to lower your blood pressure too much and get lightheaded and dizzy. And you need to work with your doctor to safely back off on your blood pressure medications, probably, if you go keto. And there's evidence to that point. I mean, there's one study that was a low carb keto diet against a low fat diet plus a weight loss drug. And they lost equal amounts of weight, but the blood pressure decreased much more on the low carb diet. There's a review in, oh gosh, I want to say the BMJ, I think, that reviewed numerous studies that looked at blood pressure and diets, and low carb diets had strong evidence to show that it helps people reduce their blood pressure. So I recommend it to patients frequently to help lower their blood pressure. But like I said, the only caveat is, like with glucose, it may work too well and you'll have to back off on your medications. Now, when you go low carb, I think this is also what you're getting at. Frequently, you need to supplement with sodium because some of the side effects are lightheadedness, dizziness, headache, even a little fatigue when you start, because it has a natural diuretic response, meaning it helps you sort of pee out extra fluid and salt. So you may need to add extra salt while you're going through that to help you feel better, help mitigate the side effects. And look, if you're worried about salt in your blood pressure, it's easy to measure. That's one thing I love about blood pressure. Just check your blood pressure regularly, get a home cuff. And if you start adding lots of salt and your blood pressure is going up, maybe you're one of that 25% and you need to take note. But I think the majority of people are going to see it's not going to go up, especially if the salt is coming on top of their veggies fried in butter, or their steak, or their fish. And it's sort of natural salt with natural foods.
Making me hungry.
Yeah.
I love it. So I got a question on a super chat on YouTube. Will the ketogenic diet reverse type 2 diabetes?
It certainly can. And again, but here it goes back to, how do you define reverse? And there's, if you want to create a Twitter storm, just type in, "I reverse my type 2 diabetes," and you're going to get a Twitter storm there.
And I do that about every 3 months, Brett. I'll just type that in. Keto reverses type 2 diabetes. Or no, I always say cures type 2 diabetes.
Yeah.
That really gets them out.
Just to stoke the fire a little bit. Yeah, I know how you like to do that, Ken. That's true. But I mean, I think what we can agree on, look, if someone has type 2 diabetes and they're on medications and they can get off their medications and normalize their blood sugar, to me, that's a reversal. Now, does it mean the condition is gone forever and won't come back if you go back to eating all the junk food? Of course not. Of course not. I don't know who would ever suggest that is a reversal, right? That's what we mean by reversal. But yet some people are sticklers for definitions and they get up in arms about that. But that's not what we mean. It means you're no longer diabetic and you don't need medications anymore. Yeah. That's reversal. Yeah. Yes.
As long as you continue to eat what I consider to be the proper human diet, right, your diabetes will stay cured or stay reversed, however you want to phrase it. But if you go back to eating the slow poison, that is the standard Western diet, yeah. So, and I use the example of poisoning my neighbor's dog. If I'm poisoning my neighbor's dog and he's getting sick, and then I stop poisoning him because my neighbor found out and had me arrested, is the dog's poisoning, is it in remission, or is the dog just not poisoned anymore? And I would say the dog's poisoning was cured because I was put in jail so I can no longer poison the dog. And if you think of the standard Western diet, the sugar, the grains, the carbs, and perhaps the vegetable seed oils, if you think of that as a very slow, insidious poison, then you get what Dr. Scher and I mean when we say you can reverse or cure your type 2 diabetes, because what we want you to do is stop eating shit and begin to eat real human food, and then to continue to eat real human food for the rest of your life. And so if I get out on bond and I go back and start poisoning my neighbor's dog again, he'll get sick again. That doesn't mean, he was just in remission. That means that he's now being poisoned again. And that's how you should think of it. If you fall off the keto wagon and you go back to eating the Hi-Ho crackers and Nabisco and Kellogg's and Kraft and all that crap, you're poisoning yourself again. So yes, the symptoms of that poisoning will return.
Yep, absolutely. It's a bit of a morbid analogy, but it works.
I love poisoning my neighbor's dog. Okay, I've had multiple questions about atrial fibrillation. Is keto safe? Will keto? Because there's a little myth out there, a little medical lie that keto will cause A-Fib. Let's talk about that.
Yeah, so there was one study that got a lot of attention a couple years ago, probably 2 years ago, that low carb diets cause atrial fibrillation. And there were so many problems that where do you begin? First, low carb was, again, 40% of your calories that so many studies use. And that's just absurd, because if you're eating 2,000 calories per day, that's still like 200 grams of carbohydrates. That is nowhere. The fact that anybody could consider that low carb is just a crime. So first of all, they didn't even study a low carb diet. Okay. And then, even then, it's nutritional epidemiology, it's food frequency questionnaires, it's observational data with very small relative risks. So even then, the association wasn't that high. But there's no study out there showing that keto diets cause or even associated with atrial fibrillation. And in fact, from a cardiologist perspective, what is associated with atrial fibrillation? Hypertension, obesity, sleep apnea, type 2 diabetes. Those are all associated with atrial fibrillation.
Those all tell metabolic syndrome or associated conditions. Absolutely.
And what can make all those better? Low carb and keto diet. So I treat my A-Fib patients with low carb and keto diets if it's appropriate. And I have no concern that it's going to increase the risk of atrial fibrillation. There's no science to support that.
Yeah, and I've had to answer that question so many hundreds of times because of that little bullcrap study that came out. And then, of course, all of the low fat proponents wanted to beat that study to death. But Dr. Scher said it perfectly. The low carb diet that they used in that study was not anything that anybody who knows about low carb would consider a low carb diet. It was still a high carbohydrate diet. And so, yes, high carbohydrate diets probably increase your risk of A-Fib. That's what the study actually proved, if it proved anything at all. CAC scores. Let's talk about that. So I've seen several examples in my practice before the fire. I'm going to start calling that BF, before the fire, that of people improving their CAC score. So they would come to me one year with a 1200 or 700, and then they would do low carb, keto, or carnivore for 12 months, and they would knock anywhere from 10 to 40% off that score. I've seen that multiple times. And then Dr. Adam Nally, who's a family doctor out in the West, I think Arizona, he's documented hundreds of cases of people lowering their coronary artery calcium score. Tell us all, as a cardiologist, what's your take on that?
Yeah, that's interesting. And I've got a bit, I've read calcium scores for, I don't know, a decade, and doing CT angiograms and reading those and performing them. And my first instinct when I hear the calcium score went down is always, well, I wonder if there was a technical issue. And, especially when you get into scores 500, 600, 700, or certainly in the thousands, it's hard. It's hard. I could do it 1 minute and then do it the next minute, and there's going to be some variation.
Yep.
The other thing is the heart rate. Heart rate's very important because you like to see nice discrete circles when you're evaluating the calcium score, and sometimes it's a smudge or a blur if the heart rate's too fast. So the point is, there are things that can happen that are technical issues that may not make it the most accurate. But if the heart rate's stable, if you have a doctor who can actually look at the images and compare the images side by side, see that there aren't artifacts like that, then sure, then it may be real. Now, my next question though is that the goal, right? Is reversing calcification the goal? And for me, I don't think it is, because we have to remember the calcification isn't necessarily the problem, right? The problem is the plaque inside the artery. The calcification measures calcium in the wall of the artery. Right. So the calcification isn't the problem, but it's a marker that you're more likely to develop the problem, which is the plaque inside the artery. So for me, anybody who's got a high calcium score, the goal is prevent development of plaque in the artery or stabilize any plaque that is there. The whole concept of reversing plaque, reversing calcium, sure, I guess it's probably better than if you didn't, but I don't think that has to be the goal. You shouldn't be disappointed if your calcium score stays stable and isn't being reversed, because the goal is preventing the problem, which is what causes heart attacks and strokes, and that's the plaques in the arteries, either to the heart or the brain, not the calcium in the wall of the artery.
Yeah, I totally agree. And it's pretty much normal for someone's CAC score to go up from 3 to 10% a year after the age of 50. And so if someone keeps their CAC score relatively equal year after year, that's actually a victory. But,
I
right?
agree with that. Yeah.
Yeah. And so a lot of people say, man, I did keto for a year and my CAC score is the same thing as it was last year. And I say, congratulations. You didn't just go up 5 to 10%, which is what would have happened probably if you'd been eating the standard American diet. Yes, guys, for those of you still asking, keto does not cause A-Fib. And if you have atrial fibrillation, A-Fib, and you are a human being, then you will benefit from eating a ketogenic diet. I don't know about other species, but if you're a human, then you need to eat the proper human diet. And anything else you want to add about A-Fib or anything else with regards to cardiology?
Yeah, well, one other thing about the calcium score. Very important concept about the calcium score is that there's no timestamp on it. And that's one of the frustrating things about trying to help somebody with a high calcium score, because they've had 50 years of their life to beat up their body in 6 months on keto. And now they get a calcium score of 300. It's like, oh my God, what am I doing to myself? It's like, well, hang on a second. Right? Because are we going to say it's the past 6 months? Or are we going to say it was the previous 50 years or 40 years or whatever the case may be? So there's no timestamp on it. That's why I'm a big fan of getting calcium scores. Just anybody, just get a calcium score to document it. You have your timestamp. Then when you get one in the future, if you need it for whatever reason, you have that comparison. Now there's some radiation involved, and people aren't always in favor of just getting any radiation just for the heck of it. But I think for most people, this will make a difference because you have that comparison since there's no timestamp. And let's face it, the radiation is very small for a calcium score, about the order of a mammogram. So I think, check with your doctor. But for most people, I think it's reasonable to get one, and at least you have that timestamp. And that's important. So following for progression, rate of progression can be important. Knowing that the higher the score, the harder it is to kind of determine if the progression is true or not. And that's where having a doctor who knows how to interpret these and can look at them side by side, or for most doctors who don't, because they send it off to a radiologist, asking the radiologist to say, compare these side by side and tell me if they look the same, if the quality's the same, if the artifact's the same, and how much can I trust this? I think that's important.
Absolutely. Tina has a question. Why does my doctor say my cholesterol will go up if I'm eating keto? Why does Tina's doctor say that?
Yeah, so that's a great question. A great question, Tina. And in some of the talks I give, I reference this Twitter post by a cardiologist who said, I implore people not to do the keto diet. Like, the language was so strong and she was so passionate about telling people not to do the keto diet. Why? Because your cholesterol might go up. Not because you're going to have heart attacks, not because you're going to have strokes, not because it's bad for you, but because your cholesterol might go up. When you actually look at the science, the majority of the studies show that cholesterol doesn't go up. Certainly LDL does not go up in the majority of people studied. What does go up is HDL. What does go down is triglycerides. What does go down is small, dense LDL particles. And in some people, there is a subset of people, hard to estimate exactly how many, anywhere from maybe 5 to 20%, LDL cholesterol can go up quite a bit, along with the HDL going up and the triglycerides going down. So some people may be in that 20% range when LDL goes up, but for the majority of people, LDL cholesterol does not go up. And you can have a whole nother argument whether that's important or not. But the facts of the matter is, for the majority of the people, it does not go up. And that's why in a lot of these trials, the cardiovascular risk calculation, when you plug them into the formula, went down because LDL didn't go up, or it went up a tiny bit, and the triglycerides went down, the HDL went up, the blood sugar got better. And the follow-up to that is, what are we measuring? Are we measuring the right thing? Because LDL-C, LDL cholesterol, isn't the best test to even be measuring. We should be measuring an ApoB, an apolipoprotein B, or an LDL particle count, because those are more accurate measures than just an LDL-C. So that's the other part to that question. So if your doctor says it's going to go up, I'd love for them to take our CME course at Diet Doctor, where we can show them that for the majority of the people, it's actually not going to go up.
Yeah, it's free. They can take that CME and actually learn to stop saying stupid things by getting a free CME. Now, there's not a steak dinner attached, but it is free. Dennis wants to know, can you reverse A-Fib on keto or carnivore?
Well, sure. I mean, you can reverse A-Fib or prevent A-Fib if you can get rid of potentially causing risk factors, which we talked about, sleep apnea being a big one, which is linked to obesity, high blood pressure, type 2 diabetes, metabolic syndrome. Those are all potentially causative of A-Fib. So whatever you can do to eliminate those potential causes, you are taking big steps towards getting rid of your A-Fib potentially. And keto, low carb, carnivore, all of those in the right setting can reverse and prevent all those diseases, which then can affect the risk of A-Fib. So yeah, I think there's a definite connection there if you connect the dots.
Yeah, I totally agree. When you lower the blood sugar and you lower the insulin and you lower the levels of inflammation in your body, things just start to get better and things start to resolve. And then, like Dr. Scher said earlier, when you're eating keto, you get to eat more salt. You get to eat it. You get to salt to taste instead of restricting your salt. And I wouldn't be surprised if sodium chloride, potassium, and magnesium didn't have quite a bit to do with the atrial fibrillation.
Yeah, you brought up potassium, so that's an important point. We should talk about potassium because when you go back to the original DASH studies, with this DASH diet that now everybody's supposed to be on. I'm using a lot of air quotes today. My kids started doing that, so I think I picked it up from them. But when you go back and you look at that data, what's so interesting about that data is it was the high sodium, low potassium diet that was more associated with high blood pressure. But the high sodium, higher potassium diet was not associated with the high blood pressure. And so one of the things about the high potassium is that's you're going to get from natural foods. You're going to get the high sodium from the processed foods but if you're getting high potassium, that means you're eating more of the natural foods and then probably less of the processed foods along the way. So I think that had a lot more to do with it than the sodium itself. So it really speaks to paying attention to where your sodium is coming from and eating real foods, proper human diet, natural foods, then the sodium is going to be a lot less of a concern, most likely.
Absolutely. And I've got YouTube videos about high potassium keto foods and high magnesium keto foods. A lot of people on keto, just because I personally think that our soil is depleted in a lot of minerals. And so eating the broccoli, each piece of broccoli isn't tested in the lab before you eat it, right? They say, broccoli has this much potassium or this much magnesium. That's a complete and utter guess based on a piece of broccoli that they tested maybe back in 1974. And so they're saying that this representative piece of broccoli has that much potassium, so that probably does too. But you don't always know that, and that's why a lot of people will use an electrolyte drop that has sodium chloride, magnesium, and potassium in it so that you're getting the right amount of that. And if you have normal kidney function, and correct me if I'm wrong, doctor, if you have normal kidney function and you take a bit too much potassium or magnesium, you're just going to urinate it out. That's how the human body's designed.
Right. I mean, the people who really get into trouble with too much potassium are the people who have dysfunction in their kidneys because they can't clear it as quickly, just like you said. Right. And if you take too much magnesium, you may get a little diarrhea or loose stools as well.
Yeah, your body will let you know if you get too much magnesium. And the other population of people who should watch the potassium is if you're taking a potassium-sparing diuretic, which is a fluid pill. And some fluid pills make you urinate away extra potassium. Some make you save potassium. And so talk to your doctor if you're on a fluid pill and make sure you know which kind you've got. But yeah, magnesium and potassium are so important. Let's see, Doc. Let me see if I can find another great question here. Anything else while I'm looking? You just take the floor and run with it.
Yeah, I mean, I think HDL is a really fascinating topic too right now that a lot of people have been talking about because for decades we've been taught HDL is the good cholesterol, air quotes again, the good cholesterol. And now people are saying HDL is worthless. Some people have even said there's no point in checking HDL because the drugs that raise HDL don't improve cardiovascular outcome, and because there are some specific genetic mutations with very high HDL that's dysfunctional that's not associated with improved cardiovascular outcome. So they take those two, the drug studies and the genetic studies, and say, therefore, we don't need to worry about HDL, don't even bother checking it. Well, that completely ignores the whole concept of if you naturally have low HDL, studies show you're at higher risk of cardiovascular disease, probably more so than high LDL. Low HDL was associated likely more so in most trials. So what's the natural reaction then should be to, well, I want you then naturally not have low HDL? And that's a completely different question than saying, give me a drug to improve my HDL.
Yep.
So does HDL work because of the reverse cholesterol transport? Part of it, I'm sure. And does HDL work because it's a marker of metabolic syndrome and metabolic disease when it's low, and when it's high, it reflects a healing of that metabolic disease? Yeah, that probably has a lot to do with it as well. And does the function of HDL matter? Absolutely. And could that be influenced by metabolic disease and hyperinsulinemia? Sure, that's potential as well. So I think people are far too short-sighted when they say drugs didn't do it and some genetic mutations don't do it, therefore ignore it. And that nothing makes me more upset about hearing that about HDL. I just think that's wrong.
I totally agree. And there's two things where they use that same logic, or that same illogic, let's call it that. Mm-hmm. And one is HDL, because they've never been able to find an FDA-approved medication that lowered or that raised HDL and also had a good clinical outcome. They can't find that pill. They've spent billions of dollars trying to find that pill. And since they can't find it, they turn around and say, well, HDL doesn't matter.
Right.
And then the second thing is omega-3 fatty acids. We absolutely know without doubt they're vital for proper brain function, proper nerve function, proper cell membrane function. But since they can't get an FDA-approved omega-3 fatty acid that really rings the bell in research studies and shows a huge improvement, instead of them saying, well, I guess you should just eat lots of oily fish then because we can't come up with a pill, they say, well, see, omega-3s are not important because we did this study. And again, they're confused that food and pills, they're two different things. One is natural and one is fake. But they want to base their opinion on the results of the fake research rather than the real food. And I just find that so disconcerting.
Yeah, we really confuse the drug culture and life, and they're not one and the same. And it's really unfortunate when the two get confused, for sure.
Not at all. Okay, Doc, we're coming up close to the hour. I just want to thank you so much for doing this. Guys, if you want to share this with your mama or your daddy or your next door neighbor, click the share button, and literally with the information that Dr. Scher has given us today, you could change their life, if not save their life, by sharing this video. You can share it on your Facebook profile. You can share it. You can put it in a tweet and tag a couple of those guys that are mean to me on Twitter. That'll piss them off. Any final words, Dr. Scher?
It's been a pleasure, Ken. I love all you're doing to spread the word and help educate and entertain people at the same time. I think it's so important to get the word out there. And again, right, this discussion doesn't mean everybody should go keto, everybody should go low carb, but everybody should at least be taught about it, should consider it, and every doctor should know how to help people start it and know when to start it, because it is a viable option for so many people that has been ignored for far too long.
Yeah, I totally agree. Thank you so very much, Dr. Bret Scher, for joining us. Tell us one more time the websites where people can find you.
Yeah, thanks, Ken. Well, dietdoctor.com, where I'm the medical director. We try to make low carb simple and help people everywhere transform their lives using low carb. So I'm the medical director there. That's where I do a lot of my writing and posting in the Diet Doctor YouTube channel. And then lowcarbcardiologist.com is where you can find more about how I work as a physician and working with me as a patient, and links to my book that you reminded me I wrote a few years ago.
Yep. And I'm going to put a link to all this in the show notes. And after this is over, I'll have a link to Dr. Scher's book that he wrote a few years back. And you guys can check all that stuff out. Thanks so much, Bret. It's always a pleasure to chat with you. We'll have to do this again sometime.
Yeah, my pleasure, Ken. I'll come back anytime.
Take it easy. Okay, guys. Thank you so much. If you will, please give this video a thumb and a comment and share this with somebody. The more people you help me reach, the more people that Dr. Scher and I can help. And that's what I'm doing this for. And so to my Facebook supporters, thank you so much for your support. To all of our patrons on patreon.com, thank you guys so much for making this possible for me to have this opportunity to help so many people. I'm Dr. Berry. I'll see you next time.